and share my screen so that you can see. All right, so hopefully you can see that now, and hopefully I did that correctly.
Yes.
Um, if people have questions as we go, do feel free to raise your hand, or you can put it in the chat as well. I have my chat window open, and I do try to keep up with questions as I go, because I know a lot of times there's something that somebody wants to hear a little bit more about, or questions that come up as we're talking. So, what I'm going to be presenting on today is a little bit about anxiety from a clinical and from a personal perspective. So, what we do as clinicians when we're serving and treating individuals who live with anxiety, which is exceedingly common. We oftentimes refer to it as the common cold of mental health. The number of people who have diagnosable anxiety disorders in the United States, absolutely staggering. And there's so many more people who would meet the criteria who don't actually have a diagnosis, haven't been identified, haven't received appropriate treatment. Also going to be talking a little bit about what that treatment looks like. So what are the things that actually help? Because anxiety is kind of interesting among psychiatric disorders. That anxiety is something that if a lot of times people who mean well trying to help actually can do things that are counterproductive. So the old sort of model of supportive psychotherapy, not always that helpful for treating anxiety, and can actually in some cases make people's anxiety disorders worse. So a little bit about what I do. So I work for Recovery Centers of America. We serve individuals with substance use disorders, and this is one of the reasons why talking about anxiety. The comorbidities are huge between substance use disorders and anxiety disorders. And they're actually differential patterns as well, where you'll see specific disorders have a specific pattern of comorbidity that may not look the same for a different anxiety disorder. The initial presentation that I pulled this from is a larger presentation at our training program, RCA Academy. I have the website up here. Please feel free to check it out. We have free trainings that offer CEs for counselors and substance use counselors. We do those, try to do about every month on topics related to mental health, substance use. We have one coming up that a colleague of mine is presenting on the neurobiology of substance use. It's going to be really interesting. I'm looking forward to that. Those are always free and they're always available online for continuing education at rcaacademy.com. All right, so we're going to specifically talk about what anxiety is, how it works in the brain and body. We're going to talk about some anxiety disorders and some of the differences between them. And then we're going to identify some of the evidence-based treatments for anxiety disorders. All right, so what is anxiety? I always like to say that, in the field of psychology and oftentimes ask really basic questions that we all think we know the answers to, but in reality, they're much more complicated. So, anxiety is a state of arousal in our central nervous system. It's a state of arousal, and when we talk about anxiety, it's also our reactions to that arousal. So the arousal itself, anxiety, is something that is necessary and it's adaptive. One of the first things that I talk to when I'm treating somebody who has an anxiety disorder, one of the first things I talk about is how, when you have these symptoms, you're feeling this anxiety, that's really just a sign that your nervous system is working the way that it's supposed to for the most part. Anxiety is our threat detection system. It's what helps to keep us safe. Now, we don't necessarily like the way always that works in our modern society, but we developed this over a very long period of time to help keep us safe from all of the risks that present themselves in our environment. Now, it becomes a problem when it starts to get in the way of our day-to-day life. So many mental disorders, and like when we talk about a substance use disorder as well, we're talking about it becoming a problem when it causes marked distress or when there's a functional impairment. So we all experience anxiety. Every single person on this call, all of us, myself included, we experience anxiety. We know what that feels like. It's a part of the human experience. But when it starts to get in the way of our ability to function at work, or it starts to become a barrier in our families or in our relationship, that's when we start to see it become something that we would describe as an anxiety disorder. I think a lot of times people, a common criticism that folks will throw out about diagnostic systems like the DSM is that, oh, you can just diagnose anyone with anything. The reality is we actually are setting a bar with that, just experiencing anxiety, we're not pathologizing that. It's that the anxiety has become significant and it's become problematic. It takes away from our quality of life. It prevents us from living a life that's meaningful to us the way that we want to do. Also, really important to anxiety is the performance arousal curve. Now, this may be something that people are familiar with. You may have seen this before, but this is a really important concept. The fact that when we look at arousal um, and our ability to perform, we actually are at peak performance when we have more arousal. And again, arousal, think about arousal as that nervous system activation that is, what we're talking about when we discuss anxiety. So having a little bit of it is actually not a bad thing. Common example that's given is, when you perform in front of a crowd, whether it is somebody at a sporting event or somebody doing a musical performance or speaking in front of a crowd, that little bit of arousal, that little bit of nervous energy that we get actually helps us to do better than if it was something that's like, yeah, kind of ho hum, sleepy, we're not really into it. That's way down here on arousal and our performance tends to suffer. But it's a curvilinear relationship. So when that arousal starts to get at the higher ends, our performance suffers. And most of us probably know what this is like if we've ever tried to do something in front of a crowd when we're feeling really worked up for one reason or another. When that arousal gets too high, it becomes difficult for us to focus. And some of our focus may become internal. So if we call that self-focused attention. If I'm so focused as I'm presenting right now on, ooh, did that sound right? Am I really making sense? Oh, is this diagram good enough? And I'm focused on all of these other things. What am I not on? I'm not focused on what I'm saying. I'm not focused on the audience that I'm speaking to. I'm not focused on what I'm actually doing. I'm focused on that sort of meta level of communication that it pulls me out of the moment. I don't have that awareness of the moment that I'm in. So important also when we discuss anxiety is that we talk about the cognitive behavioral model. Now, folks here who have some clinical training, they may well have seen this before. Folks who are not clinicians, this might be a little bit new, but it makes a lot of sense. So, cognitive behavior therapy, evidence-based intervention that we use for anxiety, for many other issues. Really, this is the basic core of it. This is take all of 60, 70 years of research and practice and boil it down to its most basic. It's the interactions between our thoughts, our emotions, our behaviors, and our physical sensations. So let's take the example of anxiety. So, how do we feel physically when we're anxious? Every one of us knows the answer to that question, and it may be a little bit different from person to person. But when I feel really anxious, I start to kind of feel it in my abdomen. You get that sort of the term butterflies in the stomach. That term is used because of trying to describe that physical sensation of anxiety, and then the flushing of the skin, and again, all of these are biological reactions to that arousal that our bodies develop, and they all have purposes. Maybe they don't work for us in the moment, but I have those physical sensations. And a big part of cognitive behavior therapy, CBT, is how do I react to things? It's not always what happens, but it's how do I react to what happens? And so, what kind of thoughts do I start to have when I start to have those physical sensations? I start to notice it. It starts to become enter my awareness. I'm like, wow, I must be really worked up right now, and I maybe have some self negative self evaluations that why am I feeling this way? Am I feeling this way because I'm doing a bad job? Am I feeling this way because something is wrong? And I start to worry about it, and that worry is then an emotion. So I start to have some unpleasant emotions. Well, what do those emotions do? They impact my thoughts. They lead my thoughts to become more negative and more self evaluative. And then what does that do to the physical sensations? Do they get better? Do I start to feel better because I'm having all of these negative thoughts and I am having this worry and this fear that's building? No, the physical sensations start to get worse. So it creates a feedback loop. And then we talked about this also a little bit already, that impacts my behaviors. So I start to focus more internally and I start to doubt myself, and maybe I start to behave differently. And so essentially all of these things create this feedback loop that certainly doesn't make the anxiety get any better. It just leads it to grow and grow and grow. Now, this model is applied throughout behavioral health. We apply it to depression. We could go through that exact same. Instead of anxiety as an example, I could have provided depression as an example. We can talk about all sorts of different areas where we can apply the cognitive behavioral model. But really, that's what's going on behind the scenes. And we talk about the cycle or the vicious cycle of anxiety or of depression or many other areas. That's what we're talking about at the core from a cognitive and behavioral standpoint. So, one of the things that we can characterize as a result of this is what we would call anticipatory anxiety. Now, kind of a big term, we love big, complicated sounding terms in healthcare and mental health, especially. We also love our abbreviations. But anticipatory anxiety is basically exactly what it sounds like. It is the fear or worry about a future event or a situation. It's not necessarily what I'm feeling in the moment presently, it's worry about future worry. It's that, okay, so I had all those things happen when I presented in front of a group of people. I felt anxious. I had all those physical sensations. I had a bunch of negative thoughts, unpleasant situation. And that's what's going on in the moment. But then what's going to happen when I think about doing that again in the future? I'm not responding to what's really actually happening around me. I'm not responding to the world. I'm not responding to my body. I'm responding to an imagined future event. So all of that happens when I'm presenting in front of you guys. So I'm thinking about, ooh, I have to, do another training next week. Wow, that's going to happen again. I'm going to feel so bad. That's going to be so unpleasant. That really sucked when that happened. I don't want to be in that situation again. That is anticipatory anxiety. So, most often, and this is a big part of anxiety disorders, it's out of proportion to the actual threat. Was there any real threat in that situation? Well, no, I was perfectly safe. Um, and did I even do necessarily a bad job, or did anybody on the outside even see that I was anxious? No, probably not. But my belief is that I did. My belief is that it is actually threatening to me. And why do I believe that? Because anxiety is our body and our brain's threat detection system. So it's not out of the realm of reality that I would perceive that as a threat. That's actually, again, it's my nervous system and my brain functioning the way it's supposed to function. But I have this perception of threat for this future situation. Now, the way that I think about that can be also distorted in some pretty typical ways. So I'm overestimating the danger uh, of that situation. I'm overestimating the likelihood of negative consequences. Ooh, if I give a presentation and I screw up and I say something that doesn't sound smart, wow, people are going to think I'm an idiot, and I'm gets my supervisor is going to find out, and I'm going to lose my job, and I'm going to all these bad things are going to happen. Exaggerating the severity of consequences. Very typical. Underestimating our own ability to cope. That's something else that is very typical to an anxiety disorder. Is people overestimate the danger, underestimate their ability to cope with that danger. So, what does this lead to? So, think about it. I have all of this anxiety about an imagined future event, probably triggered by the fact that it was unpleasant when I did that at one point. I felt all those feelings of anxiety, negative emotions, negative thoughts about myself. Well, it leads to the other big A, which is avoidance. So, avoidance is the fuel that drives or that powers an anxiety disorder. Avoidance is, it's interesting when I would, when I see somebody with an anxiety disorder, oftentimes, there's a feeling that, I'm terminally unique. Nobody else has ever had feelings of anxiety like this before. I'm the only one to ever experience this. I'm weird, strange, different, wrong in some way. But people also will have the question that, like, why did this happen? I can't figure out why I've gone my whole life without having this fear. Why do I have this fear now? Where did it come from? One little thing happened. Why did it trigger all of this in my life? And avoidance is the answer. Avoidance is what fuels and causes that anxiety to grow. So people avoid situations that cause anxiety. They'll avoid or try to avoid thoughts, try to avoid emotions in the situations that create them. And avoidance can be overt. So overt avoidance, that's the obvious thing. Do it. So I'm anxious. I'm having anticipatory anxiety about speaking in front of others. Well, I'll just not do it. Somebody asks me to speak in front of a group, I'll politely decline. Or if I am frightened of, take a simple phobia as an example. I'm frightened of dogs. Well, I'm going to, not go to the park because there could be dogs there. Those type of overt avoidant behaviors. People will also avoid in more subtle internal ways. So people will use things like safety behaviors. So, if what's a good example of that? If I'm speaking in front of other people, as long as I don't show my hands, that's actually a very common one for social anxiety. If I can obscure my hands so people don't see them, because I'm worried, oh, if people see my hands, they might see my hand shake. That's a sign I have anxiety. That's going to show people that I'm not confident, that I'm not capable. So a subtle avoidant behavior is I'm going to make sure that when I speak, nobody can see my hands. I have those obscured. Um, but sometimes medication actually can get worked into this. So people who utilize, and there are certainly some situations where it would be appropriate, and people need to talk to their doctor, their prescriber about whether or not medication is an appropriate part of treatment for them. But for some people utilizing benzodiazepine medications like Valium, et cetera, for an anxiety disorder, having that medication with them becomes a safety signal or a safety behavior that if they go out into the world and they don't have that medication with them, not having it will actually trigger their anxiety because I know I'm only safe if I have that medication with me. Substance use is another very common avoidance strategy. So, what do we know about alcohol and anxiety as an example? Well, alcohol is actually rather effective at getting rid of anxiety in the very short term. Now, of course, the long term consequences of that are very problematic. And actually, one of the things that we know about substance use disorders is people who use substances to try to change, manage, control their emotions are more likely to develop a substance use disorder and more likely to develop a severe substance use disorder than people who don't. But in that moment, feeling very painful emotions, feeling having a lot of negative thoughts, have a drink, I'm able to manage those better. So people avoid using substances, and then actually that can lead to a substance use disorder in the longer term. And, and so avoidance, what it does is it strengthens anxiety. And the reason why it strengthens anxiety, there's a number of reasons, but basically it is negatively reinforcing. A negative reinforcer is simply when something takes away something unpleasant. When you take something away that's unpleasant, you're more likely to continue you doing that thing that took away that unpleasant experience, feeling, thought, etc. So I feel horrible. I feel anxious when I approach a situation and I avoid that situation or I escape from that situation. I leave that situation. So let's take something more like agoraphobia, which is an anxiety that's created oftentimes by not necessarily social interactions like social anxiety, but by being in public settings. So if every time I go to the grocery store, I am feeling extremely anxious and I have all of those things going on that we talked about when we discussed the cognitive behavioral model. And as soon as I walk into the grocery store, I start to feel that way and I turn around and leave. How am I going to feel? I'm going to feel great. I'm going to feel fantastic because my anxiety, my arousal, my negative emotions, my thoughts were increasing, increasing, increasing. All of a sudden, boom, I feel better because I escaped the situation. So that is negatively reinforcing. It reinforces it, but then also from a cognitive or thought based level, it gives me evidence that that actually was dangerous. So why did I feel so good when I left? I felt so good when I left because I was actually in danger. So it helps to strengthen the cognitive or thought-based reaction in addition to being negatively reinforcing. So um, this is kind of an example of how this can play out. So for many people, there may be sort of a triggering event. So not everyone has an event that triggers anxiety. Or had an event specific, one event that triggered anxiety, but something leads to that anxiety, it triggers the anxiety. We then have anticipatory anxiety, thinking about being back in that situation or an event recurring or being in a spot where I'm going to experience those feelings that are unpleasant that I dislike. I then avoid or I escape from those. It negatively reinforces that. And then the anxiety trigger becomes even stronger. So this is part of that cycle. This is what people get into. And when people ask me, how come this happened? Why, I was a kid and I was never afraid of this. And I was a teenager in my 20s and I was never afraid of whatever specific thing is triggering the anxiety disorder. Then all of a sudden I can't speak in front of a group of people, or then all of a sudden I'm feeling like I can't leave my house. This is the cycle that leads to that. So now to talk a little bit about anxiety disorders specifically. So we talked about anxiety and how it works. Now, how does it actually present? How does it come out in people? Because I gave a few examples as we were going, because I talked about social anxiety. I talked a little bit about agoraphobia, which is a fear of being in public or outdoor areas. And there's a lot of nuance that goes with all of those. I talked a little bit about phobias like a fear of dogs, but how do these actually look in people? So anxiety disorders happen, as I said before, when anxiety inhibits our ability to function. It gets in the way of us living the life that's important to us. It does respond well to treatment. This is one of the important messages for people living with an anxiety disorder is there is absolutely effective treatment that is available. It's not necessarily easy, and it's not just, general, as I said, supportive psychotherapy. There's very specific cognitive and behaviorally based treatments that are helpful for anxiety. But most people who seek out help for an anxiety disorder do so not from a behavioral health provider. Most often, they're talking to their primary care provider. They may be going to the emergency department, other healthcare services. In fact, usually they're presenting for ancillary issues, not the anxiety disorder itself. So I'm having trouble sleeping. Why am I having trouble sleeping? Because of the anxiety disorder. Or I am not able to, function at work. Why am I not functioning at work? Because of social anxiety, or, et cetera, et cetera. Usually it is a somatic complaint, something going on in the body as a result of that, or it is sort of as ancillary effects, not necessarily the cause that leads somebody to seek treatment. About a third of Americans will have an anxiety disorder at some point in their lifetime. I said common cold of mental illness or mental health. That's the reason why. Of those, about 13% receive adequate care. And by adequate care, I mean, appropriate focused treatment, evidence-based treatment for their anxiety disorder. So the base rate of receiving effective treatment is so low, partially because of a lack of availability of that treatment, partially because of the stigma around mental illness and mental health care services, and also just because, so often the person is seeking help not for the anxiety disorder, but for sort of an ancillary thing that is connected with that, and their PCP or the emergency room doctor or the other healthcare provider, they may not know. They may, first of all, they may not have the experience. They're probably not assessing the person for an anxiety disorder, and they may not even know that that's what's really going on with the person. So how does this actually look? Let's talk about some actual anxiety disorders and kind of how they present. So these are four of the very common ones. I've already talked a little bit about social anxiety. I've done a lot of treatment of folks with social anxiety, a lot of work in this area. This is the avoidance and anxiety surrounding various different social situations. And it doesn't necessarily mean that somebody is entirely socially inept or that they're not able to function in society. It may be very circumscribed. This is actually something very interesting that I've had patients who have said to me that, um, I'll tell one of my loved ones that I'm going to get treatment for social anxiety, and they'll be floored. They'll be absolutely floored because they'll say, "Oh, well, you're such a social person and you have so many friends and you spend a lot of time." This is not the same thing as being introverted or as being asocial or not interested in social interactions. This is specific social situations can lead to anxiety. Now can be more generalized, but oftentimes it could be something like presenting in front of others. That's a very, very common one. The old joke is that people rank the fear of presenting or talking in front of an audience as higher than the fear of death. So if you're going to a funeral, you're better off being in the casket than giving the eulogy. That's where that joke comes from. But the idea being that there's specific settings. So presenting in front of others, dating and romantic relationships are another common one. Other contact, meeting new people. Sometimes it's very specific things like talking to somebody who is in a position of power, and that's something that again it can cause a little bit of stress for all of us. We meet somebody who is big, powerful, important. Any of us is going to get a little anxious in doing that. But again, we're talking about getting to the point where it's actually preventing the person from functioning. It's actually very disabling. People think about social anxiety as, oh yeah, that would stink to have that going on, but it's just the person's a little bit shy. It's actually disabling because you'll see people with social anxiety disorder very commonly not reach the level within their career, their profession, that somebody with their intelligence and education, et cetera, would normally achieve, because so often you have to do things in front of others as you move forward in your career or in education. And a lot of times people avoid that as a result of social anxiety. A phobia, that's a fear of a specific situation, object, etc. So I use the example of fear of dogs, fear of spiders or bugs is a very common one. There is also another very common one being fear of blood and injections. So people who are, not able to have their blood drawn. Sometimes people actually lose consciousness. So I call that a vasovagal reaction as a result of that. Panic disorder. So panic disorder is when a person experiences panic attacks. Panic attack being a very, very strong physiological experience of anxiety. So imagine those physiological anxiety symptoms that we talked about. I use example of butterflies in your stomach and feeling your skin get warm as the blood flushes. You're close to the surface of your skin. Slowing of your respiration, becoming really shallow and sort of almost feeling like somebody's sitting on your chest and you're not able to inflate your lungs fully. All of those, imagine those writ large. Like imagine, if you've not had a panic attack, imagine that you felt all of those things at like a 3. Now imagine them turned up to a 9 or a 10. That's what a panic attack is. Now, a panic attack is not dangerous. That's really important to know. Somebody who has a panic attack, it's not something that can cause, it doesn't cause cardiac problems. It's not the same as having a heart attack. It can't cause a heart attack. It can't cause somebody to stop breathing and suffocate. Although people oftentimes have these thoughts, a lot of times if somebody hasn't had a panic attack, they will think that they are having a heart attack or that there is something wrong with their lungs and they're not able to breathe as a result of that. But again, it's the anticipatory anxiety that actually becomes the biggest issue with panic disorder. So people will avoid because of a fear of having another panic attack. And usually it's not even the fear of the panic attack, it's a fear of the consequences of the panic attack. So, what if I had a panic attack while I'm driving? well, I could lose the car on the highway, crash it into another car, I could kill someone, that could happen. Or, what if I had a panic attack at the grocery store? Well, I could pass out and lose control and, wake up in the hospital. People fear losing control, or I've had patients say, I feel that I'm, going to go insane as a result of that. People will then avoid those situations. And as a result, that avoidance strengthens the association between the panic attacks and the anticipatory anxiety. And this is where the term agoraphobia that I used earlier comes in. People with panic disorder can have, they don't always, there's panic disorder without agoraphobia, but this is where people can develop that fear of going into social settings. So oftentimes what you'll see is the person's world starts to shrink, and it starts to shrink, and they cut things out, and I'm not going to the store anymore, and I'm going to order all of my groceries online because I don't want to be in that situation. And then, well, I'm not going to go out to eat at a restaurant anymore. And now maybe I shouldn't go too far from my home because I don't want to be that far away if something does happen. What if I was all the way across town? And now I'm really not going to leave home unless I absolutely need to. And you see the world just start to shrink for the person. And that is what agoraphobia oftentimes looks like. Generalized anxiety disorder is more cognitive anxiety, so thought-based anxiety, negative thoughts, fear thoughts, worry that is not tied to a specific situation. It's more general, just the term generalized, thus the term generalized. But people feel like they're controlled by their worry, like they're driven by that worry. And that worry, again, it's not just worrying, because we all worry. Every one of us worries about things, but that's worrying about things so much that that worry starts to take over a person's life. And that's what GAD is. Now, obsessive compulsive disorder is interesting. The clinicians in this group will know that OCD is now classified in a separate category. It used to be just considered a straight up anxiety disorder. It is in a separate category now. There's reasons for that, but it does fit with the general pattern of anxiety disorders in that there is the physiological arousal, there are compensatory behaviors or avoidance, and that strengthens the relationship. Now, that avoidance looks very different, or usually it looks very different in OCD, which is why OCD is sort of thought of as its own thing, or why we sometimes look at it a little bit differently than we look at other anxiety disorders. So OCD involves obsessions and compulsions. Now, the obsession is the anxiety thought. So, worrying about something negative happening, the anticipatory anxiety, fearing an imagined future event, or fearing that something has happened, or overblowing the risk and reducing our own ability to cope with it. All of the things that we talked about when we discussed the way that we have thoughts about anxiety. And then the compulsions are the avoidance. Those are behaviors that the person engages in to reduce the discomfort caused by the obsessions. So, the most common example that people will usually think of is cleaning and checking. The sort of old school model of that. Somebody has a fear of germs. That's my obsession. I'm worried that there are germs on everything. Well, there actually are germs on everything, but then use the anxiety way of looking at it. I'm overblowing the threat. So I'm over exaggerating the actual risk that's posed. So there are germs on everything, but most of them don't pose me any risk. But if I increase in my mind that risk and say, well, actually, they probably are dangerous. I could get sick. I could get very sick. I could die. I could, pass germs to people who I care about and cause them to get sick as well. So all of those obsessions build. And then what do I do in order to reduce that? I wash my hands a lot. Now, that's not pathological. I've worked a lot of my career in hospitals, and hospital people wash their hands a lot as well. We're actually trained to do that because of the fact that you don't want to spread diseases and pick up things and move that from one patient to another. So again, it's not just that they do that a lot; it's that it becomes a problem for the person. So use that as an example, hand washing becomes to the point where they have to leave situations, they have to leave social settings, they have to leave work in order to clean their hands or other parts of their body. They're not able to function. When they touch something, they're so focused on that until they can wash their hands that that becomes the only thing the person can focus on. So imagine that getting to the point that it's actually disabling, which it can be. Another example that's somewhat common is driving. So harm OCD is actually a pretty common subcategory of OCD, and that's where the obsession is about the potential to do harm to another person. And it's important to note this is not somebody who wants to hurt anyone else. This is not somebody who they're a sadist or they want to cause harm or injury. This is somebody who it's so they're so reviled by or they're so repulsed by the thought of causing harm to someone else that they're going to avoid anything that would cause them to think they had done that. Now, the driving piece is that some people will have the obsession develop that every time they go over a little bump in their car, speed bump, pothole. I live in Philadelphia. There are potholes everywhere, but they believe that they've hit somebody. So could have been someone on a bicycle, could have been somebody in the road. But every time I go over a bump, I hit somebody. Imagine what you would feel like. Imagine the thoughts you would have if every time you went over a bump in your car, you seriously, with every fiber of your being, believe you had probably just run someone over. That would be absolutely terrifying. That would be, couldn't even imagine what that would feel like. So, oftentimes, compensatory behaviors, the compulsions, people will drive back in a circle around to drive right past the same place where they went over the bump to look and make sure that there's like nobody lying there that they ran over. um Again, that might sound like okay, not that big of a deal, but imagine those feelings, like imagine the strength of those negative emotions and those thoughts. And then imagine if every single time you went over a bump, you had to circle around the block. Again, I said I live in Philadelphia. With the potholes we have here, it would probably take me 2 hours to drive like 5 blocks if I had to circle around the block every time I went over a bump. So that is the pattern. And again, that looks a little different than other anxiety disorders, which is why we are kind of talking about OCD separately. But it has the same DNA as other anxiety disorders, and that it's about the thoughts, feelings, emotions, behaviors, that it's about the anticipatory anxiety, that it's about avoidance and how avoidance strengthens the relationship with that anxiety and worsens the anxiety. And it just looks, the way that it comes out just looks a little bit different, which is why OCD is kind of looked at differently. All right. And then PTSD. PTSD is another one where PTSD is no longer classed as an anxiety disorder. It used to be. And PTSD also because it has some of the same DNA, but it does look different. It comes out differently. It's also one of the only, in fact, the only psychiatric disorder that has a required external event in order for it to exist. All of it, there's never like if you diagnose someone with depression, it's not that there has to be something external that's causing them to be depressed. That's not a part of it. There can be, but that's not a requirement. And oftentimes it's more about internal like thoughts and emotions and internal biological things like brain chemistry, as opposed to an external event causing that. But when it comes to PTSD, there's an external event, exposure to a real or perceived threat. This is a response to a terrible event, so it can be something that happened to the person, something like a natural disaster or being involved in an accident or injury, or it can be one they perceive or they witness in another person. It doesn't even have to happen to the person. It can happen to somebody else. So witnessing somebody else be the victim of a crime, seeing something that's horrible or terrible. Again, it's a very strong emotional reaction to that. Oftentimes, it creates thoughts and feelings of fear, of helplessness, terror, horror in the face of this awful thing that's happened. So then, and it's important also to note that not everyone who experiences a serious trauma develops PTSD. It's roughly around a third of people exposed to trauma actually will develop a post-traumatic stress disorder as a result. But they'll experience intrusive symptoms, so things like re-experiencing, nightmares, flashbacks, intrusive thoughts and memories about the event, avoidance symptoms. And again, here we get to the DNA of an anxiety disorder, avoidance, in which the person will begin to avoid situations that would lead them to be triggered uh, by the re-experiencing of that situation. There's also emotional numbing, hyper arousal, so things like hypervigilance. If you imagine the sort of awareness that we have when we're in a slightly unsafe situation, our situation awareness, the knob gets turned up from a 5 to a 10. Imagine being on a 10 all the time. So that's hypervigilance. Now, I know I went through those kind of quickly, but we only have an hour, so I did want to get to have a little bit of time to talk about what treatment looks like for anxiety disorders. So now that we've talked about like what is anxiety, how does it function, why is it a problem, or how can it rather become a problem for individuals, and we've talked about what it looks like for specific people, what are specific anxiety disorders, all this is going on, how does it actually look in an individual. We're going to talk about what we do and how we provide treatment for people living with an anxiety disorder. Very, very important point. Our goal is not to eliminate anxiety because we can't do that. Remember that anxiety is proof that your nervous system is actually functioning generally more or less the way that it should be. So we're not eliminating that anxiety because we can't, and also honestly because we wouldn't want to if we could, because that arousal is a necessary part of the human experience. It does keep us safe in some situations. It is part of how our bodies function, but we're breaking the cycle that we talked about. We're changing the reaction to it. Remember that I said so important to cognitive behavioral therapy is that it's not always as much what happened, but how we react to or respond to what happened. So we want to be able to reassess danger because, again, we said that we are somebody with anxiety disorder is generally overstating the risk that a situation or stimulus poses to them. Changing beliefs about our ability to cope, recognizing that we can cope with that anxiety, increasing outward focus, increasing our present moment focus, because as I said, oftentimes that leads to an inward focus. I'm thinking about my reactions. I'm thinking about what I'm doing. I'm hyper focused not on the content, but the meta content of the situation. Diminish the negative impacts and reestablish a sense of safety. So, using again the example of agoraphobia, if I don't feel safe when I go to the grocery store, if that makes me feel unsafe, I need to reestablish a sense of safety there. It's not that I need to make my anxiety disappear and not ever have anxiety. It's that when I walk through the door of the grocery store, I need to feel that I'm safe because I no longer feel that way. So, when we're treating anxiety, we're addressing the thoughts, the feelings, and the behaviors. That's another important part of that cognitive behavioral model. We have all these different parts. We have our behaviors, we have our thoughts, we have our emotions. We're going to address all of those. This is a little bit of a repeat of what I said before, that we're not trying to get rid of anxiety or avoidance. We're trying to increase confidence in our ability to cope. And one of the components that is a little bit unique among evidence-based treatments that we use for anxiety is what's called exposure therapy. So exposure therapy means facing the situations, thoughts, feelings, etc., that cause distress. So if I am anxious when I get in the car because I'm worried about the potential that I've run someone over, it's facing that situation, which is being in the car and driving and eventually going over bumps and reestablishing safety and a sense of wellness in those situations. We do this repeatedly until the anxiety decreases. I often use exercising as a metaphor or an analogy for exposure therapy, that if I want to get in shape and I go out for a run today, well, I have not run in a long time. I will fully acknowledge that I used to run somewhat regularly. Haven't done that in a little while. And if I go full bear and I go try to run 3 miles right now, first of all, I'm going to overdo it, and I'm probably not going to feel very good tomorrow. I'm probably not going to feel very good today, for that matter. But if I do that just once, what effect is that going to have on my overall health? Probably nothing, because doing something like that once really doesn't have that effect. If I want to start running, what I need to do is I need to start small. I need to work my way up to it. And if I want to get that benefit, if I want to increase my lung capacity, be healthier, I'm going to need to do it for a while over and over again. And it's the same thing with exposure therapy. We have to do it until the anxiety starts to decrease, until I start to feel safety in that situation. Usually, what people do is they'll leave the situation prematurely. Remember that escape part of avoidance? What we're doing is basically not doing that. So remember, our anxiety increases, we escape and feel better. Well, what we're doing with exposure is we are letting the anxiety go up and we're not escaping, because guess what happens with anxiety? It can't go up forever. Eventually, it plateaus and starts to come back down on its own. So it's relearning that. And you think about that, whenever you do something that is anxiety provoking, you don't leave the situation, you don't feel anxious the whole time. You start to feel better. And when people escape, they rob themselves of the second half of that curve and they get out real quick. So they don't learn the fact, or they don't establish the fact that, yeah, they're going to, the same effect you're going to get by staying in the situation as you'll get by leaving it, in that eventually your anxiety will start to subside. So oftentimes what we will do is we'll include psychoeducation. I talked about this throughout, how, there's different things that I would want to tell someone. There is a period of psychoeducation where we teach people about anxiety, about the nervous system, about why this is happening, and help them to understand you're not the only person who is ever felt this before. I can't tell you how many patients have expressed that just hearing that, yeah, there's a name for this and other people experience it and there is a treatment for it, feels so much better because they thought they're the only one who's ever had this before. Exposure therapy, which I talked about a little bit, and I'll give a few more examples of. Mindfulness is a common practice that's used. Cognitive interventions, so helping people to reframe those negative thoughts that we discussed. We may use things like relaxation training, and then emotional and interpersonal processing. So, really developing that understanding of those emotions, how they work and why they work. So exposure therapy. Now I'd actually forgotten this was on here. So this is a much better drawing of what I was just sort of tracing out with my finger. This is exactly what I was talking about. So you see the anxiety will increase over time. This red line is when the person avoids or they escape the situation, they start to feel better right away, and then they get back down to baseline. If they stay in the situation, yeah, anxiety will still go up, but eventually it will plateau. Eventually they will feel better. Here at the end point, regardless of how you got there, you're at the same spot. You're at the point where the anxiety has subsided. You will be okay. You will feel better. It's just getting there by going through the experience as opposed to avoiding or escaping from the experience. That's essentially what exposure therapy is. So you're going to face those situations. Doing so, you can do that imaginally or in some sort of a way that you're in the safety of the office and you're doing that. So commonly videos and other things where you might take somebody through it, to close their eyes and imagine being in that situation, and then actually going into the situation itself eventually. So, for example, driving. I treated actually a bunch of patients with driving phobia, whether it is related to OCD and harm OCD, as we talked about, or I've had some folks who have had panic disorder with agoraphobia, and they're specifically afraid of driving for that exact reason. I'm going to lose control because I have a panic attack while I'm driving. I'm going to swerve off the road and crash my car and kill someone, and obviously I don't want to do that, so I'm not going to drive. So exposure therapy for that is actually then driving, and I would have them drive in obviously in a very safe situation, and I knew it was safe. I wouldn't get in the car with them if I thought that potentially it would be unsafe for me or them. But have them drive and increase the perceived severity of the situation to where, initially they're just driving around a parking lot, to then they're driving on very quiet roads, to busier roads, to eventually on the highway. Because again, you're increasing the intensity of the exposure as you go, in the same way that if I'm going for a run, I'm probably going to be increasing the distance that I'm running over time as I get better at it, as I get more comfortable with it, and as I get healthier. Another example would be social anxiety. So exposure for social anxiety is involves social situations, so speaking in front of others, speaking to other people. One of my favorite stories about this, I did a lot of social anxiety exposure at one point at a super Walmart that was around the corner from the office where I worked. And so I would take patients with social anxiety in there for their sessions, and they would have specific exposure assignments. I would do it with them to show them that it was safe, and that they would do it. So walking up to somebody and asking them a question, or at the very low end saying hi to someone, it was the perfect place to do it, because there was any time of day, there were always people there, so we could always find somebody to do that. And then at the more um, the higher, more difficult ends, even doing things like making a mistake, because a lot of times in social anxiety, one of the fears is of, oh my God, I'm going to make a mistake and I'm going to be so embarrassed, and I'm not going to recover from that. So, walking up to someone who's clearly not an employee and asking them, how much a roll of paper towels cost, or, intentionally accidentally dropping something, like dropping your keys on the ground in front of some other people and saying, oops, I made a mistake, and pick it up, just doing things like that. And that would actually be a part of their exposure. And the thing about the Walmart is that eventually, I think the inventory control people had my picture on the wall, because I would come in there like every day, always with different people, walk around for like an hour, not buy anything, and then leave. So I think that eventually, they would start to like see me come in, and they'd be like, all right, man, what's he doing? So but that's what exposure therapy can look like. And again, it's very different from a lot of the other type of interventions that you might see for mental illness. And it's actually, from a clinical standpoint, it's actually very interesting and can be very rewarding to do with patients. So, for individuals who then are looking for treatment for an anxiety disorder, I think it's really important that, again, we have, they seek help from a trained clinician. So, anxiety is one of those things that, again, if somebody doesn't necessarily know what they're doing, we can actually inadvertently make that anxiety worse. A great example of that, I worked with a person once who was a college student, and this individual had a pretty typical fear of presenting in front of others. I mean, very, very common social anxiety disorder, very common presentation of it. Not super severe, but like, it would get in the way of this person's ability to function at school, which is why they were seeking treatment for it. And when I was doing an interview and talking to them, and sort of assessing for the severity of it, what I found out is that they actually had a guidance counselor of some manner at their school. And what they would do, they would register for their classes. They would go to the first day, get the syllabus. They would check to see if there was any public speaking as one of the requirements for an assignment. And then they would drop that class if there was a requirement for public speaking, and they would just register for a different class. So that was their sort of compensatory avoidance strategy. Well, their guidance counselor had found out about this, and actually then helped them by getting them the syllabi ahead of time, and helping them to only pick classes where there would be no public, which they really thought they were being helpful. They really thought they were doing the right thing to support this person. But in reality, what they were doing is they were just teaching them and providing them a more effective way of avoiding, as opposed to actually addressing and working with the anxiety the way that we would want to. So definitely want to see somebody who is experienced with anxiety, who understands the model of anxiety and exposure treatment, or exposure therapy treatment. And also, as a clinician, if you're interested in exposure therapy, this isn't something that you should do, just because you read something about it. There's definitely, if you've not done exposure therapy before, you want to get training and supervision on it. So finding somebody who can supervise you appropriately and train you on exposure therapy to learn how to provide that as a service. But it is really rewarding. It's very interesting as well. Keeping in mind also medication may be a part of a patient's treatment plan. Usually it's not the only intervention though. So usually medication is less effective for treating an anxiety disorder. Usually that would be in addition to psychotherapy as part of an integrated treatment plan. So that's definitely something that a person would want to discuss with their provider as well. So that's what I had to go over with you guys. I hope that it was helpful and hopefully, what you guys are looking for. And if there's any questions, I do have a couple of minutes left. So if there's any questions anyone has, if they'd like to ask them or put them in the chat, I'd be more than happy to respond to that. But it's been a real pleasure, and thank you guys for taking the time to join and for listening.
Thank you so much. That was excellent. I think I got a great overview of the different types of anxiety and some different coping mechanisms. My one question, is it a spectrum, like where you have general anxiety that's, mild, and then if it's not treated, it can get progressively worse, or is it usually just manifests in different forms?
I would say both. So definitely untreated anxiety disorders will have a tendency to get worse over time. That's not to say that happens 100% of the time, but because of the way, and maybe a little bit less so with generalized anxiety disorder, but in general, because of that pathway, the pattern of avoidance and how that strengthens the relationship and how that builds the anxiety. Usually, when it's not treated, you will see a downward progression where there is, or upward progression, however you want to think about it, where there are more severe symptoms over time. But somebody can enter at a different sort of level of severity too. So, we'll see some people with very mild symptoms, some people who have had more severe symptoms, but generally you will see that progression of symptoms growing over time. Oftentimes, may have some unsuccessful attempts at treatment in the past that then, in addition to not providing them relief from their disorder, also kind of reinforce for them that belief that oh, I'm unique, different, untreatable, beyond help, etc.
Thank you. We have one question in the chat. Mary
Yes.
asked,
So is it difficult to find professionals who do exposure therapy and CBT? So it can be. So one of the different things that I would ask somebody is, I would want to know if I was sort of auditioning a potential therapist, specifically what exposure they're using, or exposure, specifically what treatment are they going to use. And, if somebody says CBT, that's great. But when it comes to anxiety, you really want to dig a little bit deeper. So specifically, what are we going to do? If I have OCD, specifically what kind of treatment can I expect from you? There are some good organizations that can help. So for OCD, the IOCDF, or International OCD Federation, has a lot of resources for helping to find an effective therapist. I believe, I'm going to test it right now, but I believe it's iocdf.org, and I was correct. So iocdf.org for OCD. There's a lot of, and I'm putting that in the chat. And
thanks.
then there is the Anxiety and Depressive Disorder Association of America, or Anxiety and Depression Association of America. They have some resources as well. So, I would look at these. A lot of times, people, you can find good, exposure therapists on platforms like Psychology Today, or a lot of the places that people oftentimes will search for clinicians. But You really want to have that conversation with them ahead of time, and find out what they're going to do, and what you can expect in treatment from someone. Which, regardless of what you're looking for treatment for, regardless of who the clinician is, you should be able to have that conversation with them ahead of time. Those are very realistic questions to ask. What approach are you going to use? What can I expect out of treatment? What's it going to be like for me?
Great. One other question, we have a huge increase in anxiety among youth, and just for parents and, community members that just want to support and, not not make it a huge issue. What are some things just you would recommend? Just keep facing the fear and keep trying and not
I
maybe
mean,
go to
in general, on a societal level, anything we can do to reduce the stigma, because stigma is not just unpleasant, stigma is dangerous. Stigma prevents people from getting the support, the care, the treatment that they need. So anything that we can do to show people that it's okay to talk about. These aren't forbidden topics. This isn't something that should be bound by shame and fear. It's okay to talk about the need for mental health services. It's okay to talk about having a mental illness. It's these shouldn't be things that are at the society. So breaking down that to, and you're not there to need to do, but you're going to be there to hear what they have to say.
Great. That's excellent. That's one of our main missions and one of the things we're constantly trying to do with programs like these and other things in the community. So again, we really appreciate you being here. We appreciate everyone's participation and attendance. And if you please complete the post-event evaluation, that will help us find other great topics to present in the future. And then this recording will be posted on our YouTube channel. So if you missed it, you'll still be able to watch it again. And any other questions? Vernig, is there anything else I should have mentioned? Any other questions that you have?
No, I think it's wonderful. Thank you so much, Dr. Vernig. I attended your longer presentation, and I, haven't been in grad school in a number of years, and I took, I think, 8 pages of notes for that session that you did for Recovery Center. So excited to have you here, and hopefully we will see you again.
Oh, absolutely. It was a pleasure. Thank you so much. And everyone, thank you for taking the time to attend. I really appreciate it.
Thanks. Everyone have a great day. Get out and get some sun.